There we go. Perfect.
Perfect.
Sorry about that, guys.
No problem. Thanks, Emma. And thank you to all of you for joining us, and a special thank you to our guest speakers. Today, we're going to be kicking off our discussion by hearing various perspectives from each of our panelists. Each will have up to 10 minutes to present. And then afterwards, we'll address questions submitted by you, the audience, at registration. And as time allows, take live questions that will be coming in through the chat and the Q&A feature. So down at the bottom of your screen on the right-hand side, you'll see a little Q&A bubble. So feel free to put your questions there, and we will get to as many of those as we can during the presentation. And if need be, our very generous speakers have agreed today to follow up afterwards for any questions that we don't have time to get to. So with that, let's meet our presenters. First up, we have Linda Rowe, Senior Advisor, Value-Based Markets at InterSystems. We have Mike Kane with us today, Vice President, Provider Operations, Principal Provider Data Accuracy at United Healthcare, and Dan Hooten, Vice President of Managed Care, Hospital Sisters Health System. To get started, I'll ask Linda to go first. Linda, can you just give us a high-level overview of what the No Surprises Act is and why it's important to quality patient care?
Sure, great, thanks. And thanks to my colleagues for joining us today. So first, this was a pretty big piece of legislation. The No Surprises Act had a lot of different components to it, but basically, I think of it as hopefully a consumer protection type of legislation, trying to give patients more visibility into those bills that they often get where they are surprised, right? They say, where did this come from? A lot of it has to do with billing that's done outside of in-network providers. You go to an emergency room, they're not part of your network, you might get a bill. An anesthesiologist as part of an inpatient procedure might not be in network for that hospital. So those kinds of things. But interestingly enough, one of the components of the No Surprises Act was, it says that, an enrollee who relies on inaccurate provider network status information in a health plan's directory about a provider can actually not have to pay for care, right? Because they've basically been led sort of in the wrong direction. And there are provisions, and I'm hoping that Dan and Michael cover sort of the specific provisions, because there are some very specific things on the provider side that providers have to do, like respond to requests for updates to directory information that the payer asks for. There's also this whole negotiation process that's another piece of the legislation that allows them to go through arbitration about who pays for that balance billing. And then finally, there's sort of a number of provider requirements in terms of the directories, the accuracy, the fact that you have to remove someone from a directory if they don't give you the updated information when you request it. And again, I know that they'll cover that in more depth when they speak, but all of those things are sort of focused on how do we come to and get really good provider information. So I'm going to start with a couple of quick stories. So I've done a lot of research in this area, and so I decided that I was going to be sort of the secret shopper. And so I had this hypothetical situation where I said, okay, what if I had to find a new primary care physician? How would I go about doing that? Well, you always ask somebody, right? Who should I go to? But if you go to your health system's website and you use their tool to search for a provider and you use your criteria, I live in this area, I want to see a provider with these credentials, and oh, by the way, you want to know if they take your health insurance, and you'd also like to know if they are actually accepting new patients. So I did the search and found someone that I thought would be a great candidate, sort of somebody I might be a good fit for me as a provider. But the IDN website did not tell me two important pieces of information. It didn't say whether they accepted my health insurance, and they didn't say whether they were accepting new patients or not. So then I turned to my health plan and I went to the member site and I did a search for that same provider on the insurance, the member site. And when I got there, I found the good news is that she accepted my insurance, but guess what? The website said she wasn't accepting new patients. So at that point, well, where do you go? You kind of start all over again. So that's kind of a, sort of frustration as a patient, right? And how many of us have navigated this to try to have to find a new provider? And it's not easy because we have a shortage of primary care physicians and you want certain criteria. And maybe sometimes you just have to figure out, well, I can't get everything I want and who's actually, providing access and services. So that's sort of the first thing. The second thing or the story I'd like to tell is that my OBGYN was in private practice for many, many years, single practitioner, had his own practice, you knew what his hours were, you knew sort of all that stuff. And then he merged or became part of a large IDN, again, in our area. And so think about the provider information, right? So now he's part of an organization and he has hours that he sees patients. And there are some days that he may not sort of see patients. And if you think about what insurances does he take in this particular network, they don't take Medicaid. About 3 years ago, he decided that he wanted to do some pro bono work for a federally qualified health center. So, he now has on Fridays, he sees patients at an FQHC. Well, guess what? Think about, again, I want people to think about the data that's associated with how do you figure out, how to find this provider and what days and what hours. So at the FQHC, he does accept Medicaid. And he actually has a translator, so we can put on his provider information that he can have translation services in other languages. So I just want folks to think about the complexity, because as a patient trying to navigate this, how do I figure out, well, what days and where I might see this provider? But if you think about it from the payer's perspective, and I know Mike will talk about this, keeping track of all that is incredibly difficult. The other thing is the payer sort of often bears the brunts of the penalties, even the ones that are in place now. So if there's an inaccurate provider directory and CMS does an audit or the Federal Insurance Exchange audits their information, it's often the payer that gets the penalty. But in many instances, it's sort of the provider that needs to provide that updated information to them. It's symbiotic though, right? It's both ways. So we need updates from the provider, but it's not easy because if I'm a provider, and Dan, I think you said you contracted with probably 200 different organizations when we were chatting earlier this week. Imagine trying to keep that up to date with all those organizations, because by the way, there's not one place you can just go put that information and say, everybody come get it. We have an update for you, 200 providers. It's not so simple. So I want people to understand that this is an incredibly complex ecosystem. I think the statistics are that, providers change sort of practice locations where they're practicing, it, sort of churn about 25% every year. So that means that if nobody did anything, that at a minimum, your data is about 75% good. That's not very good at all. I think the other sort of statistic is right now, this is just $1 billion problem in terms of everybody spending all these manual processes, because if you look in a large IDN, hopefully Daniel touch on this data doesn't just live in one place, or if you've got a good system, it does, but often you've got data in your HR system, you've got data in your payroll system, you have data in your credentialing system or your third-party credentialer. So you're getting this information from a whole bunch of different sources, and you have to know not just what is the source of truth and sort of what's that golden record, you actually have to know which of those data sources do I trust for which of that information, right? So for credentialing related information, that's going to be your primary source of truth, but that might not be the source of truth for getting licensure, unless you've got your credentials check the licensure, but you also have to go out to the Division of Insurance and see if a license has been revoked. So I just sort of want to lay the sort of groundwork for, this is a consumer and patient problem, but it's also sort of this thorny challenge for both sides, for both the payers and the providers. And we hope we're going to have a great sort of thought-provoking dialogue later on once both Mike and Dan sort of give their perspectives on it. So I think that's all I have at this point, but thanks.
Absolutely. Thank you, Linda. And Linda, you may have touched on this already, but for those who don't know, the No Surprises Act does require health plans to verify all provider data every 90 days, process updates within 2 business days of receiving updated information, and remove providers from the directory if their information hasn't been verified during a period that's specified by the health plan. So next up, Mike Kane, would you give us some perspective on behalf of payers and really, how this affects payers and what hurdles you're expecting to see?
Sure. And good afternoon, everybody. EHI folks, thank you so much for inviting me, to really represent the payer side of the house, and also, I guess, the 80 or so attendees that joined. So I really appreciate it. So like I said, my name is Mike Kane. I work for United Healthcare. One of my main roles is around provider data, primarily demographic data, our online directories, that kind of stuff. Also very, very involved in the Consolidated Appropriations Act too, and the directory components to that. So the 2 key parts that Amanda just hit on, really the 2-day turnaround time for any updates we receive from providers is one of our big focuses, as is the proactive verification every 90 days of all the docs in our directory. And I'm going to hit on those 2 real quickly, but then I want to talk more generally around the foundational data accuracy component, because that's really what everything lies on. So when it comes to the 2-day TAT, we're attacking that really in 2 different ways. One is currently, just because of the way United is organized and the multiples of systems we have to deal with, the refresh from when an update is like in one of our source of truth systems to the time it displays in the directory could be anywhere from 2 to 5 days. There's all kinds of systems that have to talk to each other and refreshes, et cetera, et cetera. We're spending a lot of money to basically make that real time. And we've actually just begun that starting this year. And it's going to be a couple-year project. Such that we're calling it directory modernization, whereby we've got one of our loading staff, they key an address change in, it should be visible in the directory same day, which is a big, big win for us, especially, for folks that want to, we said, hey, we made your change, you should be able to visit, see it in your directories here momentarily. So that's going to be a big win for us. But then also on the front end side of that, you think about all the sort of maintenance updates and requests that we get from our, 1.5 million providers that we work with every year, a lot of that stuff, I would say the bulk of that stuff currently is manual. It's sort of like if you think about the claims process, 30, 40, 50 years ago, all the insurance companies, we got paper claims. There was no such thing as auto adjudication. Claims had to be paid on somebody's desk. Much of provider data activity is still very manual. Not gonna say it's paper, but it's manual. So we've got a big, big push, a multi-year project really around automating the majority of the load processes, really so that we can get to an end-to-end sort of full throughput automation. One of our providers go onto our portal, CAQH's portal, submitting a big roster, that stuff, once it's accepted, can flow into our systems automatically with no human intervention. Currently, our throughput, our end-to-end automation, probably about 1/3 of the transactions go through it, but we've got a roadmap that's going to get us close to 90% here over the next 2 years, which would be a big win. So in theory, providers make an update, nobody has to touch it, it gets updated in the systems, get reflected in the directories under 2 days, which would be a massive thing for us. The second big component really is around the proactive verification of all the data every 90 days. So we sort of got ahead of this probably 5 or 6 years ago when I first came here, and we sort of built our attestation program. And it was a little controversial when we sort of rolled it out, because we knew we had a lot of data issues. We had accuracy issues, we had inventory backlogs, we had some challenges. And we said, hey, what better way to help us identify where we have bad data than just disclosing it to our providers, saying, hey guys, we need your help. Tell us what's right, tell us what's wrong. So we started sort of presenting our data on our provider portal, through one of our applications, and it said all the docs, all the addresses, all the products they are. And we said, hey, can you help us review this and let us know where we're right, where we're wrong? And then, oh, by the way, that'll be your primary way of informing us when you do have changes going forward. So we rolled that out. We partnered with CAQH on their Direct Assure platform, and we layered it onto our roster process, because most of our larger delegated providers submit their data basically via spreadsheets. So we sort of added an attestation program. We went from basically no attestations to now we get close to 80% of all of our providers displaying in our directory, updating or attesting their data quarterly, which is a big win. But honestly, it's plateaued over the last couple of days. Went from 0 to about 80, but we've been maintaining in the low 80s since then. And I think that's one of the areas that Consolidated Appropriations Act is going after, saying, hey, for those docs that you cannot verify, you need to take them out of your directory. And that's where we're going to begin for the first time actually suppressing them, so hiding them from the directory. There, lead some challenges for us as a multi-product carrier, because most of our providers that we contract with, see our commercial members, our Medicare, and our Medicaid members. And since the Consolidated Appropriations Act really only applies to, the commercial and our exchange business, we potentially will show one doc for Medicare, but we will not show it for our commercial side. And that causes some, challenges on both the provider side and the consumer side that we're trying to work through. But I want to spend the bulk of the time sharing some insights we've learned around really the foundational data accuracy piece. And as I said, we've been on sort of a 5 to 6 year journey improving the accuracy that we've got of the data that we've got on our providers. And just like Linda said, data accuracy is a constantly changing thing. Every carrier out there could all of a sudden snap their fingers and have perfect accuracy. And then every single day you don't do anything about it, it degrades every day, every week, every month. So after a month, you could have lost, 5% of your accuracy, just like Linda mentioned earlier. So how do we do it? We had sort of a multi-tiered approach. One is we did some very, very basic blocking and tackling, operational discipline, making sure our manual staff have the tools and training to do their job. We started engaging providers actually in the process through our attestation program. We started dabbling in a little bit of technology and a little bit of automation. And then also we started really establishing partnership with some external entities that also do this for a living, CAQH, and then you guys probably are aware of this, hundreds of other vendors that are coming to us all the time saying, hey, we've got the best data accuracy. And so if you think about it, how do you judge the accuracy of our directories? And really, we came up with sort of 2 audits a few years ago, because we're trying to get to the truth. So there's 2 ways of measuring the accuracy of our directories. One is you compare it to what our providers tell us. If our providers, we've got a new group that comes on board, 10 docs at these addresses and these all products, et cetera, accepting new patients, we need to make sure our directories match exactly what the providers tell us. And then once they're contracted with us, as they have those ongoing updates, do our directories match those updates? According to that audit, we do really well. We used to stink, we do really, really well now. When you look at the actual data element level, the field level, we're hitting 99%. And at the field level, where you look at the whole doc as an entity and every little data element within it, pass-fail audit, we're over 90% there too. So very, very good based on what the providers tell us. The other way of auditing is just like what Linda mentioned, a secret shopper audit, where a member calls the doctor's office and they compare what they see in our directory to what they are told on the phone call. And that's the one we don't do as well. The whole industry does very, very poorly. I presented these findings to CMS a couple of years ago and told them sort of the root cause of it. And, a lot of their eyes were open, but, it's an industry-wide problem. It's not a United problem. Some key stats there, when I talked about auditing every little data element in the directory, we only get probably 80-something% of those are the same as what the person on the phone tells them. And when you look at the individual doctor level, almost half of every doc that we call on has something different in our directory than what they're told on the phone call. And I hope you heard my wording right there, where I use the word different instead of wrong, because again, I'm trying to get to the truth. Sometimes there are submission errors where our providers submit to us bad data through no fault of their own. It's very hard. They're dealing with 20, 50, 100 different carriers. So them having to stay on top of us and keep us informed is really hard. Sometimes they make mistakes. Sometimes we get it, we make keying mistakes. Sometimes there's technology mistakes too, but also a lot of times that person answering the phone is making a mistake too. And they're saying something different than the person in their office who's in charge of maintaining their demographic accuracy is actually sending to us. And that's a big, big challenge there. So the key is we need to get to the truth. So when we dug into those results of the secret shopper audits, you know, it was very eye-opening to us. We found out that about 90% of the defects were what we were considering provider behavior related. You know, and they were falling into really three main categories. Those defects were coming from what we call our ghost providers. And those are simply that subset of providers, that 20% that simply just don't want to attest to their data. They don't want to test, they don't submit demographic changes. They just really don't want to interact with us. And there's a couple reasons behind that too. One could be they've been in the same office for 30 years. And they're saying, United, why do you keep bugging us every quarter? I'm the same doc, I haven't changed in 30 years, I haven't moved, I'm still taking, you know, United members, stop bugging me. So they just don't want to be bothered by it. Some of them might actually be retired or providers that have passed away that have slipped through our system and we're still showing them up as active. So ghost providers are a big problem. The second one, and it's sort of the bigger, more complicated one, and those are coming from what we call our contradictory providers. And those are the ones with that they are submitting changes and attesting their data, but when you call them, they say something different. So at that point, you're like, what's right? What is the truth there? And then lastly, we're calling they're coming from what we call our box checkers, and those are providers that probably are very annoyed by our attestation process and the requirements. You got to do it every 90 days, so they'll go onto our portal, CAQH's portal, Availity's, anybody, and just check the box, blah 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 blah. Just stop bothering me. So basically, you know, they're testing the data that might be wrong. But when you call them up, they're saying something different, you know, and we're getting defects in our audits. So sort of our strategy has been pivoting where we're trying to go after that sort of 90% of provider behavior to try to help our providers. Because again, the process in the industry is just super complicated and it's not friendly or easy for providers at all. So one of the ways we're trying to do it is one, changing providers' behavior, getting after those ghost contradictory box checkers. Two, we're trying to leverage data that's accessible to us externally where we're not even dependent on providers. You know, why can't we just go to their website, you know, and tap into their website via an API through Google, which is some work we've started doing right now. Why can't we, you know, basically plug into their practice management systems and basically have them push us or us pull demographic data from them so they don't even have to do anything. They don't have to have staff dealing with us. They make their data available to us. We pull it. We don't ever have to bug them. Our systems always match their system, which is one of our sort of, I think, transformational ideas we're trying to pursue. And then on the flip side, while most of what we've been doing has been on the incentive side, the carrot side, now we're starting to pursue some of these sort of sticks where we're, you know, I don't want to say punish it, but the suppression piece is one. You know, if at the end of the day, we can't get data, we can't confirm it from you, then we're just not going to display you in the directory. You know, will you feel that? Will our providers really feel that or notice it? I don't know. I'm sure eventually some of them will. But at the end of the day, our members don't have that kind of information available for them to make a good healthcare decision.
Thanks, Mike. And I want to make sure that Dan has time to get in his presentation here too. So maybe we can circle back and hear a little bit more about that during Q&A.
Sounds good.
Okay, great. Thank you. And
as I say, Mike, if you need to finish your thought, go ahead and I'll make up the time. Don't worry.
I think that was it. I was talking the behavior piece and then leveraging external data. And again, that's where, hey, you know, we don't want to bug our providers. We'd much rather be able to get data from them. Well, we're not, you know, it's not a handoff. And then lastly, you know, we still have, you know, a big technology program, you know, just to make sure once we do get the information, ensuring that it's correct when we get it and making sure it flows through our system automatically with no human intervention. But again, I just want to say, you know, data accuracy, director accuracy is a shared responsibility between payers and providers, and it's hard and it's complicated. And I feel for our providers that we have to deal with, because not only are they dealing with us, they're dealing with every other insurance carrier they're contracted with. Take it away, Dan.
You were eavesdropping on one of my calls this morning, Mike. So this is actually step 2 of cleaning up directories, because CMS in their 2020 interoperability final rules started with step 1. and they asked for most of the same information. The No Surprise Act then added additional requirements that we have to supply. And as Amanda was pointing out, yes, I have hundreds of contracts, or rather Linda was pointing out earlier, I have hundreds of contracts to maintain in different states. And the states may have different requirements. So the complexity on our side gets to be nuts every 90 days when a spreadsheet is requested, because there isn't a lot of direct into the system access, but the columns are different, the format is different. And so now we're maintaining hundreds of different models of the same information that we have to send out. And that always makes it fun. Now, where we can get delegated credentialing, there are a lot of advantages. One, we get the physician credentialed a lot faster than going through the process. And we collect it all one time and shoot it out to everybody. And then hundreds of people are not out verifying the information because it's already been done. That makes life a lot easier and gets a lot better information exchange and more accurate information exchange between the provider and the payer, which helps to alleviate some of the problems Michael was just talking about. Where we can't get that, the process is a lot slower. The spreadsheets become a pain to be loaded. Anytime you have manual intervention, you have errors starting. And you hear a lot when you're sitting on my side. And I've actually sat on both sides of the table, having spent a good segment of my career with one of the national major payers. Garbage in, garbage out. Where's the garbage come from? Is it at the front end? Is it all the manual exchanges? Is it in the system upgrade, which I heard earlier this month, 2 weeks ago, when I was threatening to terminate because a big payer suddenly said I had 2 out of 9 hospitals in one state out of network and all the physicians. They did a system upgrade and somebody flipped the wrong switch and we are out of network. So all of a sudden we can't get anything authorized if it needed authorization. Where it didn't need authorization, we got denials. And in this era of value-based contracting, boy, did we just screw up the value-based program because it took a month to fix. And we still don't have the claims paid for the physicians. So we're still working through all of that. So the impact is pretty good when mistakes happen. And it was simply a mistake. It wasn't intentional. But this morning's call with a different payer, it was the same issue. All of a sudden, a handful of providers are out of network. They've got to go figure out why and get them back in. But again, it's happening. So you never know where the errors come from. They could have started with us. They could have been in all the transitions, all the system upgrades. You never know. So as Michael was pointing out, the IT capabilities on this side and the interoperability of our credentialing program for delegated credentialing to get right into the payer system to do those updates. That makes it smooth. It also makes it trackable to see where the mistake happens when there's a mistake that shows up in the claims that we all see 30 days later. But it makes it much easier for Michael to hit his 2-day turnaround time. But that's a heavy lift because of all the, how many thousands of hospitals are there in the United States, let alone hundreds of thousands of physicians that you've got to do all of that with. And with not legislation, but rules that get promulgated and released in October, go live 3 months later, and you don't have the final rules or even guidance written yet. And they're just holding off on enforcement, but the rule's in effect, the law's in effect, and you don't know how to play the game. That makes it lots of fun. So that makes it some of the things that we're dealing with on a daily basis. My rule of thumb was as soon as the directory is released, it's wrong. Because people move, people pass away, unfortunately, We all do. All kinds of things happen. So these kinds of problems are what we deal with on a regular basis. Delegated credentialing and interface is the long-term solution. But as Michael pointed out, those IT solutions are years in development and implementation. The law gives us 90 days to get it implemented. So we're operating under the law now. They're just not enforcing the penalties yet. That will happen soon. So that to the point that we can understand what it takes to do the things Michael's talking about and that we need to do. Once we get there, having an accurate data or directory so that people can, as Linda was pointing out, find the physician, understand what networks they're in. Because not only do we have to do it in the directory, it's incumbent upon us as providers to get it on our website so that when Linda is looking, is the hospital in network? One box is checked. Then the physicians you want, are they in network? And you would think the physician practice would be the source of truth there. But then none of us put, are we accepting new patients? We haven't gotten that sophisticated yet, but we need to. That's not in the law, but it's one of the things that should naturally come. Before No Surprise Act came out 5 years before, we secretly shopped ourselves to see for the common procedures that everybody has to have, could we give you an estimated cost? We failed miserably. Depending upon where you went, you got a different result because there was no standard process. So we were way down the track of developing that standard process for the top 500 procedures, either at the physician level or the hospital level, when the No Surprise Act started coming down the pike. And that made it a lot easier because now everything's on the website through transparency, which was the other side of this coin. So I'm looking at the time and I see I've got us back on time, so I ought to quit now while I'm ahead.
Dan, can I ask you a quick question though?
Of
So I
course.
know you said you failed miserably when you were trying to do sort of the estimates, right? The good faith
Yes.
estimates. I don't know how you could do it without knowing the accumulators and where I'm at in my deductibles. Because what I'm gonna have to pay out of pocket actually will depend how far into my, if I have a high deductible, how far into it I am, because I certainly know I got a very large bill for my first MRI of the year because I was not that far into my high deductible plan. So I'm just curious, like, I don't think you could even do a good estimate without some data from, you know, folks like Mike.
So the first thing we tried to do was to give a total cost estimate. So based upon were they with United, which product with United, and they wanted, and I'll just say a colonoscopy. Everybody knows what that is. I usually use a urologic procedure as my example because my father was a urologist, but I'll stick to colonoscopy here. And we would go with that and then assume that the person could understand what their copay deductible requirements were and how much they had spent. There are various tools out there that give interface into at least the big plans so that we can see who has started using deductibles and meeting those and what copays are, so that at registration, and just about every big health system has one of these tools, so that at registration, you have some idea of what to ask for up front, if that's part of your process in revenue cycle. The hospital I was with in Atlanta had that, for example, a decade ago.
Thank you. That's helpful.
You know, what we couldn't do was find a person who could look up the contract to see what the colonoscopy cost was, to then pass that along with whatever estimates would be for anesthesia or anything else that might be needed as a result. And the more we went into complex cases, the harder it got.
Okay. And I see we've got a number of questions showing up here in the Q&A. Keep those coming in, and I'll apologize. I think I've got some background noise here, so I'll ask the question quickly and go back on mute. Michael, I saw that you were interacting with Janice about individual state regulations and APIs. And Janice's question was really, with more states starting to put their own provider directory requirements in place, such as the recent Massachusetts draft regulation, seems like there's a whole lot of different requirements to balance between federal requirements and the various state requirements. Would you all like to speak on that?
Yeah, hopefully I typed my answer in a way, but the big answer is yes. Almost all the states have their own unique requirements. We've got a lot of folks that really just, listen to them, even the legislation that's being teed about in the state before they become law, to make sure as soon as we get it, we vet it, we implement it. Some of the stuff right now we're trying to figure out how do we do it. I want to say Colorado's got some pretty unique ones when it comes to a lot of it is around really cultural competency type stuff right now, because at the end of the day, I think every provider, hospital system, and every carrier want our docs to be as culturally competent, sympathetic, knowledgeable as possible. But how do you do that? Who gets to define that? Is it a simple training course you take? Is it experience? Is it your own personal experience? It's hard. So it's a challenge in the industry right now, because I think folks are starting, or states specifically are starting to put these rules out there without really defining, what is the best way to do this? We've got a lot of discussions actually that I'm participating in now with like our chief health equity officer around, what do we think would be best for the industry, in terms of culturally competent providers. One of the things we actually started doing a year and a half ago was, for the first time ever, voluntarily asking for race and ethnicity data from our providers. We did a lot of research. A lot of our members are interested in this, said, hey, if you provide this kind of data in our directories, it'll help me make better decisions. We surveyed a bunch of providers, and the majority of them said, sure, we'd be willing to give this to you. But there's a big just concern, and I want to say cynicism, rightfully so, from our providers around, but what are you really going to do with their data? And what we've said, all over the places, we're collecting it simply to put in our directories to help our members make a good decision. We're not going to tier you. We're not going to pair you. It's not going to affect financially claims or anything like that. It's just member information. So, we're starting to dabble in some of those sort of non-traditional demographic data elements, that we know our members want. It's going to help them make better decisions. And I think that's what we're trying to get to.
But Mike, I think, to your point, once you keep adding those other types of data, even if it's a small narrative that goes with that provider's profile, that just adds yet one more source, right, that you've got to keep updated and maintain. Same thing with, language. What languages does this practice or this provider support? Do they have competency, or even having something that says they have a language line? Because I know we don't support every language in the FQHC that I'm on the board of, right? But we have language line if we don't have an interpreter for that language. But again, you just keep sort of adding the layers to the web of what you have to keep updated. And I totally understand as a patient wanting to understand that information, but you have to understand, if we don't have the systems and processes for sharing and moving that data around in a way that actually is easy to maintain and update, it makes it just that much more burden on both sides.
And I think that you've all touched on a couple of concepts and areas that are very near and dear to my heart. One being interoperability, and the other being policies and regulations. I'm curious, we've talked a lot about the need for good information exchange, and we've talked a little bit about the variances and disparities across states and policy and regulation, but recognizing that there's also a great deal of disparity in technologies and in technology utilization. I'm curious, from everyone's perspective, what kind of technology is necessary to create a single source of data that is as reliable as possible? And I'll say both on the provider and the payer side.
I'll jump in. I don't think it's a technology challenge. It's an adoption challenge. And it's, we could, I bet between me and Dan and our teams, we could come up with a database that's updatable, that has all the information that they think that we need and we think we need, get it out there. But it's a matter of now everybody's got to start using it, both on the payer side, and the provider side. And that's the hard part. CMS has the NPED system. Nobody uses it. They use it to get MPI, never go back again. So that's not a solution. It doesn't contain a lot of the data that all the payers use. California is trying to roll out a statewide database through their IHA process, where basically all California docs have to go and keep it updated, and then they're going to provide it to all the carriers. That's a solution, but again, for us, that's one state out of 50 that we do business with. So again, I don't necessarily think it's a technology problem. I think it's everybody just all shaking hands saying, hey, we're going to do this.
I would agree. We have been privileging to differentiate from credentialing. In hospitals, this industry has been privileging physicians for 100 years to ensure that the procedures they say they're going to do, they were properly trained on. And as new techniques come down the road in the middle of their career, they've gone out and got the training on so that they can do them. We've been doing that, like I said, for 100 years. Credentialing, where we make sure that they've got the training, the education, and have passed all their boards to practice the specialty they say they want to practice, to go into the directory. We've been doing that since managed care came along in the 30s. It's the dedication to maintain the information accurately. And as mobile as the world is today, what was it we said earlier? 25% of them have moved or changed in some manner in a year. Something in that file on them has changed. So in 4 years, it's completely wrong. That's the hard part of this. And that's what Congress was looking at and CMS is looking at. How do we force the dedication to keeping it accurate so that the consumer can rely on the information so that they can get access to the healthcare system early and often, so that the overall cost starts to come down, because we're impacting total medical costs because we can address the issues early as opposed to late. Now I'm on my soapbox for the next negotiation with United.
So it's interesting because there certainly have been some legislative things that have come out of, rulemaking out of CMS. There was patient access APIs, which had a provider directory component where payers have to expose a certain subset of data through APIs. And sort of my thought on that is that's great, because at least it's providing the information and people could start to compare and contrast. And I'm sure there are third-party aggregators that are doing that. But if the data that Mike is sharing is not good in the first place, I don't know what that's going to do to help, other than providing a mechanism. The other thing is those APIs are FHIR-based, right? But providers actually don't have a requirement to share that same data using FHIR APIs yet. And again, that may come down the road. Certainly some subset at the end of the year will need to be shared as part of the US CDI. But again, that doesn't cover what would need it under the provider. So I think, the ecosystem of exchange may be moving in the direction, but you still have to sort of maintain the integrity internally before you start sort of sharing that information. And obviously, I think one of you said, the industry technology to sort of do that compare and contrast and exchange is further down the road.
Yeah, I'll throw something else out there. And I think, in a perfect world, it's the industry coming up with the solutions, not legislators mandating it. Because again, we're in it every single day. And a good example, I think, where the industry has come up with a very effective solution is with CAQH. CAQH, it's basically a nonprofit. They've got representatives from most of the major health carriers. Most providers have to go CAQH initially during the credentialing process because it's an industry solution. They added a portal there to keep their demographics updated. And again, it's mainly for the smaller provider practices and the individual providers. But we work with, I think, close to 400,000 providers where we get their demographic data directly through there. They call it the Direct Assure portal. The accuracy of that is extremely high. And basically, they go update their data in Direct Assure. Then they don't have to worry about, 10 or 12 carriers they deal with, because CAQH automatically shares it with Aetna, United, and Cigna, Humana. And again, that makes it easier for the providers. What CAQH had not had up until this past year was a solution for the big systems like Dan, the ones that manage their data via these big spreadsheets. You know, many of the groups have different formats, many of the carriers have different formats, and sometimes it takes a month going back and forth, just agreeing that, hey, I'm going to agree that you're not going to fill this out. And then once we get it, again, it's a big, ugly spreadsheet. CAQH rolled out a new system for those big, larger groups called ProView for Groups that we're partnering with them on, trying to get our groups to adopt it, because it's cool. It's electronic, it's digital. You know, they upload their rosters basically electronically. It tells you in advance if there's sort of errors that are being submitted. You know, if you submit a doc with Jacksonville, Florida city, but the zip code is in Alaska, it flags that for you and says, hey, fix it before you move forward. You know, just like Amazon does when you order something. And then once it's uploaded, then all the carriers that partner with CAQH goes and pulls their data themselves. So no longer does that system have to send, you know, United their spreadsheet and their term file, their change file every month, and Humana a different format, and 15 different others. They can go to one place and keep it updated. You know, and again, I think as there gets some more and more momentum behind that, you know, there's going to be some providers out there to say, hey, I'm not going to contract you. I'm going to keep my data updated with CAQH. You need to go out there and partner with them and pull it yourself. You know, and I think that's it's something that nobody's making anybody do. Providers and carriers are using it just because it's easy, it's efficient, and it's very high accuracy too.
So I'm interested, Linda started out really talking about the patient perspective, and I'm curious to hear a little bit more about what everyone thinks is the impact on patients when provider data is inaccurate or difficult to get to for whatever reason, and how that patient experience then influences their relationship with either the provider organization or with the payers.
I'm watching that one here in the state that I'm in with a different provider group and a different insurance company than anybody represented here, where there's a contract dispute and they parted ways. And one of the local television stations did an expose on the inaccuracy of the directory. And it was this year, so it's, you know, it's recent. And it was highlighted, and they used obstetrics as the example, because that's a heart wrencher when somebody's expecting and all of a sudden their doctor's no longer in network and they're just outside that last trimester. So now they've got to find a new doctor, and there aren't any. The directory said there were a lot. There was an egregious error in the directory where the physician involved had never practiced in this state, was at the other end of the country, but somehow it had ended up in there. So they harped on that one quite a bit, as you can imagine a news report would on television. And the state doesn't have a good regulation to impact this particular problem, but they found another way to find the insurance company. But still, there are a lot of people that are scrambling to find an OB that they can go to. It's really a problem because they can't rely on the directory. And when they can find someone in the directory, so many of them are now overwhelmed, they close their practice. So,
yeah, it's interesting. I saw Janice put a comment in about her experience. And I certainly know that since I'm in the Boston market, I have a lot of choice on where I can go for providers. And so I would start with my main sort of provider organization to look there. But guess what? If I can't find a new provider in the large IDN that I'm currently in, I'm going to go actually to my payer site and start looking outside of that network, right? I'm going to start looking to say, who's going to take my insurance that might be part of some of these other large IDN networks that exist, or private practice within the Boston market, where I can go get care. That's not what you want to do. It's really frustrating, especially if you've had a lifelong relationship with a particular practice, because I've been in the same primary care practice since I was 25 years old and came to Boston, right? So you don't want to part ways, but in a way, at some point, if it becomes that difficult to get care there, you may start thinking about switching, right? Which isn't good for that long-term relationship that you've had, you know, forever.
Michael, any thoughts on that from the payer perspective and the relationship with patients when it gets complicated with inaccurate data?
Yeah, we've got, again, we hear about that all the time. And again, the root causes of some of the information that's in the directory that's different than what they're told on both sides. You know, it could be an update that we may not have gotten, could have been an update that we process incorrectly. Another, you know, phenomenon that we're seeing in these sort of secret shopper calls too is, you know, do you take me? You know, are you accepting new patients? And we create our own problems because our product names sometimes aren't the most intuitive named products, you know, especially on our Medicaid side. So they're reading this product name from an ID card to a provider's office who was like, what is that? I've never heard of that. But if they said, hey, do you take United Medicaid? Oh yeah, of course we take it.
Yeah.
So in lieu of that, they tell the person, no, we don't take that. So think about the member experience there. It's really, really poor. Or, and again, this is sort of, you know, again, not the best too, but sometimes when it comes to reimbursement levels, you know, or certain offices don't potentially may not want to see any more Medicaid patients, you know, and they say, hey, no, our panel's full. We're not accepting anybody anymore because of they're worried that they're just not going to get reimbursed fairly as they would if they saw more commercial members. You know, we've seen that anecdotally in a handful of our secret shopper calls too. But at the end of the day, you know, it's the patient, it's the member that, you know, they need to see the doc that's best for them, you know, and if they're getting bad info in our directories or they're getting bad info on the phone when they're trying to make an appointment, they're the ones that pay.
Right. And to that point, Jim just asked a question in the chat. If a patient uses services that the provider is listed in the directory, but the provider's not actually in network, but they didn't know that at the time, who ends up paying the provider?
Though I've actually got that one. That was one I anticipated. So the law says that the patient is only responsible for their in-network portion. And then the payer, because of their inaccuracy, the penalty is they've got to make up the difference between the out-of-network portion and the in-network portion. So the law does a very good job there of keeping the citizen, the patient, whole for relying on an inaccurate piece of information.
Great, thank you for that.
And we sort of did something similar to that years ago on our Medicare side, where if one of our members went to the directory, saw this doc was par, went there, and at the end of the day, for some reason, he or she wasn't through anybody's fault, then we would only hold the member responsible for the par rate, and then we'd make up the difference on the back end too.
Great. And seeing that we're almost out of time, we've got time for one last question. There have been a few questions about penalties and fines, and one specifically about how an organization can minimize their exposure to fines.
Well, I'll throw out just an example of something new. So we do Medicaid business in the state of Louisiana. The state regulators do secret shopper audits of our directories, I think quarterly, it might even be more often than that. But they might give us a list of 30 discrepancies and say, hey, $10,000 a discrepancy. You know, we work with them and go through each one of those and could say that, hey, but the address we have, that provider just attested to that accuracy a week ago, and it matches that, you know, or that, you know, providers submit us a term notice the day before, and they did get termed out of our system a week later, but it just wasn't in that, you know, few hour time span. We go through every one of those defects with the regulators and they go, yep. We're still going to fine you for every single one of them. So there's some instances you just pull your hair out. It's like, you know, how do you win there? You know, we do our best to explain, again, no fault of anybody, but this is the reality of what happens. But there's some bodies out there that are going to fine you regardless still.
Sure. All right. And any last thoughts from any of our speakers?
I just want to thank our attendees and Mike and Dan for joining me today. And again, I think this is an incredibly complex problem that we're all trying to solve. I think if we approach it as a team sport,
Mhm.
that's the best way, bring folks like us who are trying to find solutions in the tech space and folks on the provider and payer side. It's got to be, because again, we're not trying to do anything to harm patients or to mislead them. It's just a really intractable problem right now.
All right, and we have so many questions in the Q&A and in the chat that I think we could do this for another hour and keep the conversation going at least, maybe longer. But again, I want to thank everybody who's joined today. And I believe that we will have the ability for our speakers to continue to follow up and answering questions that are left here. So Emma, anything else from you?
Nope, I think that's it. Thank you so much, everybody.
Thank you to EHI
Thank you.
for hosting and sponsoring us today. We appreciate it.
Definitely.
Thank you.
Definitely.